Thanks, David and Frederic, for wonderful discussions. It leads me really nicely into a discussion of some of the adverse events related to these agents. We know that these are, as you heard, agents that work through a relatively novel mechanism, that is the disruption of primarily TRK signaling in NTRK fused cancers. David very nicely presented the efficacy of these agents, which in my opinion is impressive. And Frederic nicely discussed how we find and diagnose these alterations. But let's also keep in mind that there are some adverse events, and so we'll spend the next 10 minutes or so really looking at some of the unique features of the side effect profile of these agents. Now, the two agents that are approved are shown at the top, larotrectinib and entrectinib. You saw the data just now. But of course, there are other agents that are being developed. Interestingly, there already are agents being developed to address potential resistance to larotrectinib or entrectinib, especially resistance through mutations in the binding pocket. This is, of course, a common mechanism for small molecule inhibitors that target a specific alteration. And in fact, the one that you see in the third row is fairly advanced in its development with clinical trials ongoing. So let's look at the safety profile of the currently approved agents and the data that are available. Here you see a pooled analysis of adverse events with larotrectinib with a data cutoff of February 2019. So this was almost about a year ago. And what I've done is, first of all, the list is by the most frequent AEs encountered. And you can see that overall, actually, the numbers are relatively low when we think about some of the other agents or chemotherapies, cytotoxic chemotherapies that we can sometimes use to treat these tumors. Fatigue is at the top with a overall incidence of about 30%. But what I've highlighted are some of the either adverse events that can show up as grade 3 or even grade 4. And one of the unique adverse events of these agents, and that is dizziness. We'll talk more about the dizziness in a second, but let's keep in mind that these agents can increase liver transaminases, both ALT and AST, as you can see here. But let me emphasize again that the number of certainly grade 3 or 4 events remains fairly low. And now this is an updated pooled analysis of the adverse events with larotrectinib. The data cutoff now is July 2020, so more than a year after the previous one. And you can see that as the data mature, essentially we see similar adverse event profiles with similar frequencies. You see the ALT and the AST increases, you see the dizziness. But one adverse event at the bottom has beginning to emerge as a mechanistic toxicity of these agents, and that's weight increase. Now, again, the frequency is relatively low, although I suspect that this underestimates the overall numbers. But the important thing here is that this is a different adverse event that is tied into the mechanism of these agents, and we'll talk a bit more about that in just a moment. In fact, David alluded to that when he spoke about the normal function of these genes in physiology. And from larotrectinib, we can also look at entrectinib. And what we see here are some similarities between the agents, fatigue again showing up, dizziness and increased weight, as well as some increase in both AST and ALT. And this is now data cut off for May 2018. Well, very nicely, Liu and colleagues published this paper in Annals of Oncology just last year, characterizing the on-target adverse events caused by TRK inhibitor therapy. And this was the design of their study. It was a retrospective analysis. They defined on-target as pronounced and adverse pharmacologic effects of the target molecule of interest. And they defined off-target as essentially the converse, that is, adverse events as a result of modulation of other target molecules that may be related biologically or totally unrelated to the target of interest. You see the eligibility criteria. Patients were in the early drug development service of the Memorial Sloan Kettering Cancer Center between the years of 2013 and 2019. And of course, they had to be treated by these agents. The data included demographics, toxicity assessment, and adverse event management. The treatment emergent adverse event analysis included 4 particular events, that is paresthesias, weight gain, dizziness, and pain with temporary or permanent withdrawal. And let's go to the next slide and take a look. Here you see the demographics and baseline characteristics. Essentially, is almost 100 patients. You can see that the histologies were pretty typical, favoring lung and GI because of the commonality of these cancers, but you can see some of the other cancers that David mentioned in his talk, salivary, thyroid, sarcomas, etc. You can see that the genomic alteration was an NTRK fusion in about 40%. Entrectinib, of course, does target ROS1, so you see ROS1 fusions there, and some less common other alterations as well. Most patients received a first-generation TRK inhibitor TKI, and about 30% of patients received another. And of course, those don't add up to 100 because some patients receive more than one. And here you see the safety profile of the on-target AEs with TRK inhibition. Most patients did not have any of these adverse events, as you saw from the earlier tables with larotrectinib and entrectinib. And for those who did, it was primarily grade 1 and grade 2. But the important thing is that these are mechanistically different adverse events, and they are unique to these agents. Nicely summarized mechanistically by TRK-A, TRK-B, and TRK-C inhibition and the resulting adverse event. You can see, for instance, that the weight gain is likely related primarily to TRK-B inhibition with hyperphagia or hyperdipsia as a result of that inhibition. It is interesting, the dizziness can manifest as an ataxia and can be alarming to patients. The withdrawal pain is definitely real. Patients can experience that, and it can be severe, as you can see, 11% grade 3. Here is a little bit more about the weight gain. We'll get into some of these, some of the particulars of the management in the next few slides. You can see that it's really supportive management, and you can see also that the frequency increases the longer the patient is on the agent. And as you saw from David's presentation, there are many patients who are on these agents for many months, even a few years. So the frequency does tend to increase, and it can go up to grade 3. In fact, a quarter of patients who are on these agents for 2 years or more experienced grade 3 weight gain. I won't belabor the different supportive agents that were used in the MSKCC experience, but suffice it to say that these are obviously all approved agents. But difficult to say that one necessarily works better than the other. And the authors recommended to monitor weight during treatment with a TRK inhibitor. By the way, the weight is lost when the agent is discontinued. Here you see dizziness. You can see how it's experienced as well. Some patients really have difficulty characterizing it other than dizziness. Some patients, it feels like an ataxia or an imbalance. For some patients, it's a vertigo. For some patients, it's positional. And there in the table, you can see some of the strategies employed to deal with either the ataxia vertigo feeling or the orthostasis. And again, the authors recommend to characterize and manage it accordingly. You can see that withdrawal pain management or withdrawal pain is also fairly common. And again, the authors highlight that it can occur with either temporary or permanent TKI treatment and anti-track activity discontinuation. Sorry, this is transient. It does eventually go away, and analgesia is the recommended management. And then lastly, to conclude, that identifying AEs related to track inhibitors are important. There are on-target AEs with track inhibition, as we talked about. I won't belabor that, but there were certainly limitations of this study. It's a retrospective design. Only 40% harbored an NTRK positive solid tumor, and it really is still a relatively small sample size. But of course, we are gaining more experience with these agents.